Welcome to this educational program. This module provides an overview of kidney cancer. There are other modules available that describe different treatments for kidney cancer in greater detail. This information is taken from a recent review of the medical literature and attempts to be as comprehensive as possible. However, it may not necessarily reflect the experience of your healthcare provider or the specifics of your situation. Please feel free to view this presentation as many times as necessary. You may also use the player on your left to repeat slides or to skip through them in any order you wish. More than 30,000 cases of kidney cancer are diagnosed in the United States each year, accounting for 2 to 3% of all adult tumors, and this rate is rising. These cancers cause about 12,000 deaths per year, which is about 2% of all cancer deaths. The mean age at diagnosis of kidney cancer is 65 years, and it is 2 to 3 times more common in men than in women. About 1 in 3 patients have metastases or spread of disease at the time of diagnosis, and the survival rate in these situations is very low. However, when detected early, kidney cancer is usually curable. The kidneys are a pair of bean-shaped, fist-sized organs situated on either side of the spine in the upper abdomen and lie behind the bowel and other abdominal organs. They are protected by the lower part of the rib cage and the spine. The kidneys are vital organs that have many functions. They remove waste from the blood as urine that accumulates as the result of normal metabolism. They control fluid and electrolyte balance. They regulate acid-base concentration, activate vitamin D and erythropoietin, a substance that stimulates red blood cell production, and they play a significant role in blood pressure regulation. The kidneys are composed of many different types of tissues and cells, but broadly they consist of a filtering system, the meaty red part of the kidney called the parenchyma, and a drainage system that carries urine from the kidney down to the bladder. The renal parenchyma is divided into an outer part called the cortex, which is the filtering mechanism, and an inner part called the medulla, which is the collecting area for urine. It is easy to think of the kidney as an organ where blood goes in and urine comes out. Above each kidney lies an adrenal gland, and each kidney and adrenal gland is surrounded by fatty tissue, which is a protective mechanism in place so that the kidneys do not get damaged by trauma, such as jarring accidents and direct blows. The fat acts as a shock absorber for the kidney. It also acts as a natural barrier preventing local extension and spread of kidney cancers. Around all of this is a tough fibrous membrane called Gerota's fascia, which is also important in limiting the spread of cancer. Like all major organs, the kidneys are also surrounded by lymph nodes, small glands that play a central role in fighting infection and disease. The kidneys receive blood supply from usually 1, but often 2 or more renal arteries, which arise from the aorta, the largest artery in the body. This is the large blood vessel that takes blood away from the heart to the remainder of the body. Blood drains out of the kidney through 1 or more large renal veins, which then drain into the largest vein in the body, called the inferior vena cava, or IVC, that drains blood from the body back to the heart. This drawing shows how the kidneys are surrounded by other organs in the body. On the right, the kidney sits below the liver, next to part of the beginning of the small bowel called the duodenum, and beneath the right side of the large bowel, or colon. On the left, the kidney lies below the spleen and stomach, beneath the left colon, and adjacent to the tail end of the pancreas. The lungs and chest cavity are also in close relation to the kidneys. This is what the kidneys and other organs look like on a CT scan or MRI, where the body is viewed in slices, like cutting someone in half and looking up from the feet. Kidney cancer is the abnormal, uncontrolled production of cells in the kidney that have the potential to spread outside of the kidney if not discovered early. Cancer cells can form a mass called a tumor. A malignant or cancerous kidney tumor can invade and damage nearby tissues and organs and can also enter the bloodstream or lymphatic system, spreading to form new tumors throughout the body. Benign tumors can grow large but do not invade. Several different kidney cancers can occur in adults, but renal cell carcinoma comprises about 90% of cases. Renal cell carcinoma is a malignant tumor in the cells lining the kidney tubules, the tiny tubes that filter the blood and remove waste products. There are a variety of subtypes of renal cell carcinoma, which will be discussed in more detail shortly. Transitional cell carcinoma accounts for 5 to 10% of all kidney tumors and forms in the lining of the renal pelvis. Wilms tumor, also known as nephroblastoma, accounts for about 5 to 6% of all kidney tumors. It is the most common kidney cancer found in children, but it is rare in adults. Renal sarcomas comprise less than 1% of all kidney tumors and are masses that begin in the kidney's connective tissue. There are several non-cancerous or benign tumors that can affect the kidney, and the three most common are listed here. A pseudotumor is a lump that looks like a tumor but is not. It is simply a dense collection of normal tissue, and it can be congenital, meaning that you were born with it. This is not malignant and is usually of no clinical significance, except that occasionally it can be confused with an actual tumor. An oncocytoma is a benign growth of renal cortex cells forming a tumor. Unfortunately, it can be very difficult to distinguish from a renal cell carcinoma, and often the diagnosis is not made until the tumor has been completely removed. Finally, an angiomyolipoma, or AML, is an abnormal collection of blood, muscle, and fat cells forming a lump. These can grow large and can bleed, and they are usually easy to distinguish on imaging because of the fact that they contain significant amounts of fat that kidney cancers do not usually contain. The rest of this presentation focuses on renal cell carcinoma, the most common type of cancer affecting the kidneys. Looking at cells under the microscope, pathologists can subdivide renal cell carcinoma by the type of cells that make up the tumor. This provides important information about how aggressively the tumor might behave, and also has implications regarding further treatment options that are available after your kidney tumor is treated. For example, if it spreads elsewhere in the body. Subtypes of renal cell carcinoma include clear cell or conventional type, papillary type, chromophobe type, medullary type, sarcomatoid type, and collecting duct carcinoma. Although the exact cause of kidney cancer is unknown, studies have identified the following possible risk factors, or associations with the disease: smoking, age, most often occurring between 50 and 70 years old, male gender, a family history of kidney cancer, polycystic kidney disease, chronic kidney failure and/or dialysis, a procedure to clean the blood using a machine outside the body, a high-calorie diet, possibly low vitamin E intake and high vitamin C intake, and diuretic use, a drug that increases the production of urine. Furthermore, kidney cancer may be associated with certain genetic conditions such as von Hippel-Lindau disease, hereditary papillary renal cell carcinoma, or tuberous sclerosis. It may also be associated with workplace hazards such as exposure to asbestos, cadmium, benzene, herbicides, lead, organic solvents, and blast furnaces and ovens used in iron and steel manufacturing. Finally, kidney cancer can be associated with obesity, high blood pressure, sedentary lifestyle, and long-term misuse of certain pain medications, such as phenacetin. Tobacco increases the chance of developing kidney cancer by about 40%, making it perhaps the major risk factor for this disease. In fact, cigarette smokers are twice as likely as non-smokers to develop different forms of kidney cancer, and cigar smoking may also increase risk. It is estimated that the elimination of smoking would reduce the rate of renal cell carcinoma by 1/3 and the risk of renal pelvis cancer, called upper tract transitional cell carcinoma or urothelial carcinoma by 1/2. These days, kidney cancer is commonly picked up incidentally on ultrasound or CT scans done for other reasons. In fact, 25 to 40% of patients now present this way. Some patients do, however, present with some symptoms, and these may include blood in the urine, called hematuria, flank pain, which is low back pain on one side, a mass or lump in the abdomen, fatigue, weight loss, fever, loss of appetite, swelling of the ankles and legs, called edema, anemia, a low red blood cell count, and high blood pressure. Interestingly, kidney cancer in the past has been called the internist tumor because it can present in so many different ways. Patients used to be referred to internists for evaluation of these odd symptoms, who would search for a cause until ultimately finding kidney cancer. Most of these symptoms and signs will go away after the kidney cancer is treated, as long as they are not due to spread of the kidney cancer to other areas of the body. The evaluation of kidney cancer begins with a thorough medical history and physical examination. A doctor will ask about symptoms and exposure to risk factors for kidney cancer, along with general questions about the medical history, medications, etc. He or she will then check vital signs such as blood pressure, do a general exam, and will then specifically examine the abdomen and side for lumps and other abnormalities such as swollen lymph nodes. Laboratory tests may also be performed, including blood tests to measure kidney function, blood counts, and liver function. A urinalysis is also usually performed, a microscopic inspection of the urine that looks for the presence of blood and other substances not seen by the naked eye. Finally, urine cytology is occasionally performed to look for abnormal cancer cells in the urine, especially if your doctor is concerned about a tumor called transitional cell carcinoma, which frequently sheds abnormal tumor cells into the urine. When a diagnosis of kidney cancer is made, referral is made to a urologist, who is a surgeon specializing in diseases of the male and female urinary tracts and the male reproductive system. This includes cancers arising in the urinary tract. In the evaluation of kidney tumors, some type of imaging will be done to look at the kidneys, the urinary tract, and other parts of the body. This helps to both diagnose and stage the extent of disease to find if there is any spread outside of the kidney. Diagnostic imaging studies may include an ultrasound, a CT scan, MRI scan, an intravenous pyelogram or IVP, angiography, and bone scans. An ultrasound uses high-energy sound waves that bounce off internal tissues and organs to form images. A CT or CAT scan produces detailed cross-sectional images of the urinary tract as an X-ray machine rotates around the body. An MRI scan uses a magnet, radio waves, and a computer to also make a series of cross-sectional images. An intravenous pyelogram, or IVP, involves dye injected into a blood vessel which collects in the urine and shows up on an X-ray. An angiogram involves dye injected into the kidney to map the blood vessels that feed the kidney tumor. And bone scans involve a small amount of radioactive material injected into a vein that collects in the bones and is detected by a scanner to show rapidly dividing cancer cells. It is important to understand that in the evaluation of kidney tumors, biopsies are rarely done. This is for two reasons. First, if a mass looks like a kidney cancer, then there is a 95% chance that it is. Secondly, there is a possibility of spreading cancer with a biopsy. The rare exception to this rule is when imaging cannot clearly determine a diagnosis of cancer, or if your doctor feels that the diagnosis would change the treatment. Biopsies may also be done as part of certain protocols for tumors that are being followed expectantly. When a person is diagnosed with kidney cancer, he or she is obviously concerned about the chance of cure with treatment. The chance of cure depends on a number of factors, including the age and general health of the patient, the stage or extent of tumor, in other words, whether it is confined to the kidney or spread beyond it, the size of the tumor, the grade or aggressiveness of the tumor, which is defined by what the cells look like under a microscope, and finally, the type of tumor and its DNA or genetic material. Most kidney tumors start growing in the kidney tissue called the cortex, and they can spread to surrounding fat, adrenal gland, lymph nodes, renal vein and IVC, nearby organs, for example the bowel, or to the bloodstream and other organs, such as lung, liver, bone, or brain. The stage of cancer describes the extent to which it has grown and invaded or spread. This is the most important information in determining prognosis, or chance of cure, and in planning treatment. There are two commonly used systems to stage renal cell carcinoma: the Robson staging system and the widely used TNM staging system, developed by consensus among the American Joint Committee on Cancer, or AJCC, and the Union Internationale contre le Cancer, or UICC. TNM stands for tumor, nodes, and metastases. For every tumor, a stage is given to describe the tumor, as well as the presence or absence of spread to lymph nodes or distant sites called metastases. This slide shows the most commonly currently used staging system based on the TNM classification. In stage 1, the tumor is 7 centimeters or smaller and is limited to the kidney. In stage 2, the tumor is larger than 7 centimeters, but is still limited to the kidney. In stage 3, the tumor may be of any size, with or without spread to the fatty tissue around the kidney, to an adrenal gland, to a renal vein or IVC, and/or to one nearby lymph node. In stage 4, the tumor has spread beyond the layer of fatty tissue around the kidney to more than one nearby lymph node or to other organs, such as the bowel, pancreas, lungs, liver, or bone. Recurrent renal cell cancer is cancer that has come back after being treated. The cancer may come back many years after initial treatment in the kidney or in other parts of the body. This slide shows a stage 1 tumor that is small and confined to the kidney. A stage 2 tumor is similar, just that it is larger in size. This stage 3 tumor has spread into the fat around the kidney or adrenal gland and also into the large veins draining the kidney, the renal vein and IVC. This stage 4 tumor has gone completely beyond the confines of the kidney and Gerota's fascia, the fibrous covering of the kidney, into the neighboring bowel. As shown here, generally the more extensive the tumor, in other words, the higher its stage, the less likely that treatment will cure the cancer. Fortunately, when kidney tumors are diagnosed early, they're usually treated successfully with surgical removal and have survival rates in the order of 80 to 100%. After the tumor has been removed, a pathologist will microscopically grade it according to how much the tumor cells differ in appearance from normal cells. The grade indicates the tumor's aggression level, how fast it is likely to grow and spread. High-grade tumors, therefore, are the most aggressive and the most likely to progress beyond the kidney, especially when they grow to large sizes or high stage. In case you are interested, here are the key statistics on kidney cancer. 70% of patients present with a tumor confined to the kidney, and these people have a 70 to 100% cure rate, highest with smaller tumors. 30% present with locally advanced or metastatic disease, and these patients unfortunately have a 0 to 20% 5-year survival rate. When cancer is discovered incidentally on imaging, in other words, when a patient has no symptoms, cure rates are higher, on average 85% versus 62%. One important point is that 30 to 40% of patients after surgical removal may have a recurrence later on, which emphasizes the importance of careful follow-up after surgery. There are many different kinds of treatment for kidney cancer, and the type chosen depends mainly on the stage of disease and the patient's general health and age. Observation with regular imaging is an option in some situations, including very small tumors, older patients, and those who are not candidates for surgery or other therapy. Surgically removing the cancer is the best option for cure in most cases. Tumor ablation, such as with freezing, radiofrequency, heat, or ultrasound, is an emerging option for small tumors but still considered experimental in many cases. Embolization involves blocking off the blood supply to the tumor and is used to help control symptoms when a tumor is not resectable, or to shrink a tumor prior to surgery. This is not a curative option. Unfortunately, kidney cancer does not respond to radiation therapy, so there is little role for this except for controlling some metastases. Chemotherapy is also not used much for treatment of renal cell carcinoma. However, another type of drug treatment given intravenously, called biologic therapy, is an option when surgery cannot cure the cancer. Finally, a new type of drug treatment, called targeted therapy, is emerging as an excellent option for these difficult cases. An operation to remove part or all of a kidney, called a nephrectomy, is often used to treat renal cell cancer. Radical nephrectomy involves removal of the entire kidney, along with surrounding fatty tissue, gerotous fascia, nearby lymph nodes, and usually the adrenal gland, though not always. In a partial nephrectomy, the surgeon removes only part of the kidney that contains the tumor, to preserve as much normal kidney as possible. Either of these options can be performed through one large incision or cut called open surgery, or through several small incisions and the use of telescopes called laparoscopic surgery. Radical nephrectomy, or complete kidney removal, is usually chosen when the tumor is large or in a very central location within the kidney, and when the other kidney is normal and not likely to be affected by other kidney disease. On the other hand, partial nephrectomy is usually chosen when there is only one kidney, when the other kidney has poor function, or if the other kidney may be affected by an existing kidney disease. Nowadays, this operation is also often chosen even when the other kidney is normal, so long as the tumor is small, usually less than 4 centimeters, and amenable to this type of surgery. There's a lot of press about laparoscopic surgery these days, and it is true that many kidney operations are now performed in this way. Having said this, open surgery is still the choice in many situations. For tumors growing into veins, for very large or advanced tumors, or when there has been certain previous surgery. Some surgeons may also simply have a preference for this approach. For most other cases, however, laparoscopic surgery is now the most common choice. Arterial embolization is used to shrink a tumor prior to surgery, or to relieve symptoms of an advanced tumor that cannot be surgically removed. In this procedure, a doctor called a radiologist inserts a long, narrow tube through a blood vessel in the leg into the main blood vessel supplying the kidney. This is done using X-ray guidance. Small pieces of a special gelatin sponge or other material are then injected through the catheter into the blood vessel to block off the blood supply to the kidney. The kidney and tumor will then shrink. The first few days after the procedure can be painful due to inflammation, and hospitalization is usually required. Occasionally, embolization is done prior to operating to make surgery both safer and easier. Tumor ablation is another alternate therapy for patients who cannot tolerate extensive surgery. Tumor ablation destroys a tumor without surgically removing it, using freezing, heating, radiofrequency energy, ultrasound, or lasers. Since renal tumor ablation is a relatively new procedure, long-term results are still unknown. However, ablation may be less invasive than nephrectomy and may permit a better chance of preserving kidney function in situations when multiple tumors are present. Chemotherapy uses drugs to destroy cancer cells. As mentioned, current chemotherapy has been ineffective in treating kidney cancer, and is presently not a standard treatment. Research, however, continues, trying to find new drugs that can fight kidney cancer, and your doctor may place you into a clinical trial that tests these agents if your cancer has spread beyond the kidney and is not curable with surgery alone. Biologic therapy, also called biotherapy or immunotherapy, is a treatment that enhances a patient's immune system to fight disease. Interferon alpha and interleukin-2 are the two most commonly used agents for this therapy. These are substances naturally produced in small quantities by the body in response to infection or disease that can be made in large quantities in the lab then injected intravenously. New treatments being studied include stem cell transplants and vaccines. Immunotherapy can be given before or after surgical removal of the tumor. Unfortunately, with current treatments, response rates are only 10 to 20%, and the high-dose therapy used is quite toxic, with significant side effects. Targeted therapy uses drugs or other substances that can find and attack specific cancer cells without harming normal cells. Recently, two drugs, sunitinib, also called Sutent, and sorafenib, have been developed. These fall into a category of drugs called multikinase inhibitors, and these are revolutionizing the treatment for advanced or metastatic kidney cancer. Multiple clinical trials are ongoing, and it is through these trials that most patients are presently being treated. Monoclonal antibodies are molecules that specifically seek out tumor cells and inhibit blood vessel development in kidney cancers, and can also carry therapeutic drugs to it. These have also been evaluated for use in treating advanced kidney cancer and are another example of targeted therapy. New types of kidney cancer treatment being tested in clinical trials include tumor vaccines, gene therapy, and stem cell transplants. Tumor vaccines use a patient's own malignant cells, removed during surgery and treated before injection, to stimulate the body's immune system to fight cancer. Gene therapy introduces genetic material into a person's cells to fight disease. Stem cell transplants involve injecting healthy stem cells, which are precursors to other cells, into cancer patients. These stem cells then grow into and restore the body's normal blood cells. Although these therapies appear promising, they are still experimental, and it is unclear whether or not they will prove to be effective treatments for advanced kidney cancer. Even when kidney cancer seems to have been completely removed or destroyed, there is a risk that cancer may return later. A doctor will therefore need to watch a patient for any recurrent or new kidney tumors. Doctors will usually follow a patient for 5 years after the diagnosis and treatment, at which time most patients are deemed cured. Routine follow-up consists of periodic assessment by a physician, blood tests, X-rays, and ultrasounds or CT scans. While every course of kidney cancer is unique, there are steps that all kidney cancer patients can take to boost their own recovery, such as incorporating regular exercise, eating a well-balanced diet high in fiber and low in saturated fat, and quitting smoking. Medical conditions such as high blood pressure, diabetes, high cholesterol, and obesity all have the potential to cause deterioration of kidney function, and treatment of these conditions may therefore help prevent kidney damage. In summary, most kidney tumors are potentially cancerous, and renal cell carcinoma is by far the most common tumor found. Most kidney cancers are sporadic. In other words, there is nothing definite that causes them, although a number of factors listed in the presentation may increase one's risk. The chance of curing kidney cancer depends mostly on the stage, or extent of tumor, and the grade, or aggressiveness, of the tumor cells. Surgery is the most common treatment for curing kidney cancer. Removal of localized tumors is usually curative. Other treatments listed in the presentation are used as necessary for certain cases. Close follow-up after treatment of kidney cancer is very important. Here are just a few of many resources available to educate you on kidney cancer and to help you find support. These references were also used to assist in preparing this presentation and are available through the internet or your local medical library. We sincerely hope that this module has furthered your understanding of kidney cancer. We wish you the best for the future, and thank you once again for viewing this educational program.